Thank you for the opportunity to present my work here on behalf of Nonacus. So I work in the Institute of Cancer Research in London, and we use Nonacus products for clinical profiling of cell-free DNA in pediatric cancer patients. So just a brief introduction. Most of you probably know that liquid biopsies are the application of minimally invasive molecular profiling using blood or CSF or saliva to look into cancer patients and what the mutations they have, what copy number changes they have. And there's a lot of different applications for it at different stages of the disease. For example, so at early time points, you could use it for screening and cancer detection. Once you know the patient has cancer, you could use it for molecular profiling and then prognostication. Once a patient has surgery or the treatment, you could use it for detection of minimal residual disease. And then through serial sample collection, you could use to monitor disease response and monitor clonal evolution in these patients as well. So my project has been focusing on molecular profiling and serial sample collection to monitor the response to treatment. So liquid biopsies are quite well advanced in adult cancer patients. However, pediatric cancers are quite different from adult ones. They have different mutations, different genes are mostly affected. They have much fewer mutations, so much less things to track. And the mutation profile is quite often disease-specific. That's why we can't just take the things that are on the market for adult cancer patients. So we looked into designing something ourselves that would be specific for all the solid pediatric cancer patients. And to do that, we used Nonacus, which have a booth here today as well, and we designed a targeted NGS capture panel for cell-free DNA profiling. And the design currently has 66 genes for mutation calling and 32 genes for copy number calling. However, it's easily amendable. You can always add or remove genes if new information becomes available. And the clinical validation of this panel is already published, so you can have a look into it in much more detail. And today I'm going to show you some new data where we applied this method to a much bigger patient cohort to see the clinical applicability of this. So briefly, the method that we're using is we collect the blood or CSF samples from pediatric cancer patients. We extract, not working anymore. So extract cell-free DNA. We prepare sequencing libraries using unique molecular identifiers, and then we use the same library to do capture sequencing of the regions we are interested in at a very, very high depth. And then we also use the same library to run low-coverage whole genome sequencing, which gives us a view of large-scale copy number changes in each patient, and also it provides an estimate of circulating tumor DNA in our cell-free DNA, meaning what percentage of the DNA in the blood is coming from the tumor itself. And we have an in-house bioinformatics pipeline that allows us to call the mutations and copy number changes as well. So we applied this method to the Stratified Medicine in Pediatrics clinical trial, which is the flagship UK program for relapsed and refractory pediatric and young adult patients run there by Lou Chesler in the Institute of Cancer Research. So we collect time-matched blood and tissue samples at relapse for these patients, and we've analyzed almost 400 patients with different solid pediatric cancer types to see, is it useful, which cancer types is it most useful, are there any limitations to this method? So just as a brief overview, from these patients, we've collected around 6 mL of plasma, and then if you look at the plot in the middle, you can see that the cell-free DNA yield is quite variable in different cancer types. However, if you look at the circulating tumor DNA fraction, you can see that neuroblastic tumors and some Ewing sarcomas have very high purities. You can detect cancer fractions of almost 80% in some of these patients, which gives you very high sensitivity. Over some cancer types, as CNS tumors, you can see they have very low purities, very low levels of circulating tumor DNA. So we profiled all 388 patients on low-coverage whole genome sequencing and the panel sequencing. And from the panel, we found that in 178 patients, we had detectable mutations or copy number changes. However, there's quite a lot of patients that don't have any mutations covered by our panel. Most of them are actually sarcomas who have fusions, and fusions are not covered because they're much harder to find in cell-free DNA, especially in NGS-based methods. So from low-coverage genome, we can also look at copy number profiles, and we can compare diagnostic material with the tissue at relapse. So in these cases, we can actually use low-coverage genome sequencing to create phylogenetic trees and see the evolution of the tumor as the disease progresses. So at the graph at the top, you can see the first plot is from the plasma of the patient at relapse, and the bottom one is from the tissue at relapse. So you can see they look exactly the same, kind of giving us evidence that we can use blood-based profiling in these patients quite confidently. And we can see that there is a lot of changes compared to the diagnostic tissue, which is the bottom panel there. And then we also looked at the in-depth panel sequencing, looking at mutation detection. So these two Venn diagrams show the detection of single nucleotide variants in cell-free DNA versus tissue. As you can see, we detect like half of the mutations expected from the tissue sequencing in cell-free DNA. And we detect quite a lot of cell-free DNA unique variants, which indicates that we can actually detect tumor heterogeneity in these patients because we miss these mutations in the tumor sequencing, but we do pick them up very confidently in the blood. And the ones that we missed that were in the tissue but not in the matched blood, mostly due to the fact that not all tumors shed circulating tumor DNA into the bloodstream. If we look only at the patients that had circulating tumor DNA purity above 10%, we pick up almost all of the mutations, which is shown in the Venn diagram on the left. And we started seeing quite quickly that different cancer types show different results. For example, neuroblastic tumors have very high purities, and they show very good concordance between tissue and cell-free DNA. And we also detect quite a lot of cell-free DNA unique variants. So in these oncoplots, it's color-coded. So the purple variants are the ones where we detect them both in tissue and in cell-free DNA. The blue ones are the ones where the mutation was in the tissue but not in the cell-free DNA. And the orange ones are the ones where it's cell-free DNA unique variants. And neuroblastic tumors are known to be heterogeneous, and these patients are at relapse. Some of them already have metastatic disease at the time of profiling, which just highlights that actually blood-based profiling could give you a much better indication of the heterogeneity of the tumor that's present in these patients. And one other use of liquid biopsies is monitoring disease progression. So this is just one example of a patient with neuroblastoma where we had serial samples throughout the treatment. So you can see at the first, so this is, each dot on this graph is one blood sample. So as you can see, the first one, we detected a pathogenic ALK mutation at very high levels in blood and in tissue and at the relapse. And based on that, the patient had been given targeted treatment with lorlatinib, which is an ALK-specific inhibitor. And as soon as 1 month into the treatment, we don't see any circulating tumor DNA in the blood. We don't pick up the mutation anymore, and we've been following this patient for almost 3 years now. And as you can see, the patient eventually experienced a clinical relapse, but we picked up the reemergence of the mutation much earlier, almost 6-7 months before the clinical relapse, which gives us good indication that actually this could be used to monitor patients and give clinicians a bit more time to plan for further treatment. However, there are still some challenges. For example, brain and CNS tumors don't seem to be very good for molecular profiling based in blood because probably due to blood-brain barriers, cell-free DNA doesn't really cross into the bloodstream, so there's not so much circulating tumor DNA in the blood in these patients. However, we're looking into collecting CSF for these patients because that's much closer to the actual tumor, and there has been studies showing that you can detect mutations much better in that bioanalyte. So just to sum up, we have developed a clinically relevant pan-pediatric solid tumor NGS capture panel, which is optimized for cell-free DNA. And we propose that it has the potential to replace or at least complement tissue biopsy testing in a lot of clinical diagnostic situations, especially the ones where tissue profiling is not possible, where you can't do the biopsy. And also it allows detection of tumor heterogeneity and identifies the variants that could be missed by tissue profiling. So I'd just like to finish by thanking Nonacus again for my opportunity to speak here and all of the labs involved in the Institute of Cancer Research and the Royal Marsden. Thank you.